When you're doing pre-op teaching, of course you got to teach them about all this stuff, not the swan and stuff, but like this is how you're going to wake up. You might be tied down, but there's going to be one nurse with you all the time in your room, that kind of stuff. As far as like the heart video, does the patient have to watch the heart video prior to, like, to see what their surgery is going to be? What do you think? No. It's a good idea. And we can encourage, right? Remember, no confrontation. We don't make anybody, now we do make them get out of bed, but we don't make them watch the video. I've had patients that are like, no, I can't, that's going to make it worse. And if they won't watch the video, I'm going to teach them how to do the IS before surgery, right? Because when we talk about learning, they're not ready to learn right after surgery, so they better learn the IS before. And you can say 10 times an hour, or you can say, every commercial, do a couple, whatever. You can make it so it's easier to remember, make it more manageable. You also want to teach them pain level, because they're not going to be able to talk, and I want to know if you're in pain. So you teach them, put their hands up, and tell me if you're in pain, that kind of stuff. And I usually, personally, as soon as I get the patient back, we straighten them out. So within the hour, I let the family come in, see that they're alive, kiss them, and tell them, go home and get rest, he's going to need you tomorrow. And because you don't want them in your way. And there's absolutely nothing they can do. But they also need, if you've ever had a family member go to surgery, you wonder if they're ever going to come back. It's a horrible feeling. And especially they're going to crack the chest and do all this stuff, right? Life-changing surgery. You've got to let the family in there to at least see they are physically in the bed, they have a name with a nurse, and usually then they can go home. That's the best compliment they can give you on night shift. When the family goes home, they trust you. You like them to go home anyway, but Okay, so I'm just going to, let me erase this and then I'll talk about this patient very carefully, because I'm going to put it on YouTube. So Gil's patient, he's a real character. So he got extubated for Gil yesterday, and he was really eager to get up, and he wanted to move, and I was like, that's really odd. But he was getting IV push pain meds and stuff, right? And they got him out of bed. I mean, all that was great, and they even pulled all his lines and stuff, so it was a super example of what should happen. So we went in there this morning, and he's like, I'm sore today. Can I just rest? And it was funny. And I was like, darn it, somebody already brought him his breakfast. He's already eaten. I can't even say, get you up. When I worked night shift, I would like to get the patient up before day shift came and have them sitting in a chair ready to do breakfast. And it's easier, for the nurse that way and better for the patient. And then they can get them back. But they should be getting up for every meal. That's the goal. So I told him, I said, oh yeah, you can rest, but you're going to sit up for lunch. Did he call you a slave driver or something?
Oh, he was just cracking jokes.
Oh, yeah,
like
he
that
was
all
just
day.
funny. Yeah. So anyway, yeah, he was a character. Okay. So the patient, I think I'm just going to, I don't know if you want to record this. I'm not going to say anything specific about the patient. I'm not going to violate any, or am I being recorded right now? Okay. Okay, so we've got an open heart patient, and I forgot to say they have pacer wires and stuff too sticking out of their chest. And they come back and we run all of their numbers, right? So we've got the most important labs, right? We've got the potassium, we've got the creatinine, we've got the PTT. Those are going to be the most important. Troponin we're not going to worry about. They might do one, but it's going to be high, right? Because we've cut onto the heart. But it gives us a baseline if the doctor's concerned about an MI during surgery. and then it should start coming down. Just like post-heart cath. The troponin goes up after the heart cath, then it should start trending down. Okay, so we don't call with that first one, unless you want to be yelled at.
Okay.
Like, well, yeah, I know it's high, and it's 2 o'clock in the morning. You know, that's usually the worst time to tell them what they already know. Okay, and then we're going to have our blood pressure, we're gonna have our heart rate, we're gonna have our SAT, and then we're gonna run our numbers from our Swan. So the Swan-Ganz catheter is named that way for the guy that invented it, Swan, something Swan. And it's easier to say, and it just stuck. It's also called a Thermo Dilution catheter. Because when you get the cardiac output, we would inject water that's cooler than the patient's body, and it would get diluted with their blood. And then the catheter goes around, it goes through the right atrium, right ventricle, and then up into the pulmonary artery. So the cool fluid would be injected, and it would make its way through the circulation, and then because of the technology in the, the catheter, it would determine how fast it took for the cool fluid to get to the end of the catheter. And then it calculates what the cardiac output is, okay? Now we don't even have to inject fluid because they have that little machine, that hemisphere, and it does it for you, which is totally awesome. But it was fun when we had to do all the numbers and stuff. So thermodilution, right? Temperature dilution, so that's why it's called that. It's also called a PA catheter, which is probably the most aptly named because it's a catheter that goes in your pulmonary artery, right? It's a very dangerous catheter. Usually we don't want things in people's pulmonary arteries, except blood. Okay. So the numbers we're going to get that are important, we're going to get a cardiac output, we're going to get a cardiac index, we're going to get an SVR, and everything also has an index, but I'm just telling you this, the need-to-know stuff. Okay, SVR, because that's enough. And then the PAD or the wedge, we're going to just have them be the same thing for our purposes. Is that everything? Oh, and then the SVO2. So the venous oxygen. Okay, so the potassium we're going to do like on a Q6-hour interval, and then we're going to replace it or leave it alone. Okay, and the orders will be already there. The creatinine, of course, we're looking at renal function. The PTT, if it's too high, we're probably going to give protamine to reverse it, and then redraw until we get a good PTT. The blood pressure, of course, we need to have a high enough mean to perfuse everything. So though 60 is okay, very, very minimally, we're probably looking at 70, a little bit better mean. Heart rate, dysrhythmias, okay, EKG, super important. And then we have the SAT, which we all know and love. So cardiac output is, and I mentioned this before, stroke volume times heart rate. And this one, the index is based on your BMI. So you can have two patients with the same cardiac output, right? So you've got Betty 20 years ago and Betty fat and happy, right? And they both have a cardiac output of 5. It takes a lot more blood to perfuse fat and happy Betty than it does, skinny Betty. So this is not really, though it's a good number, it's not as helpful as something based on their body. So then you get their index, and this one, they both have the same cardiac output, right? This one is like 1.8, and this one is 2.5. So this patient is doing great, this patient is dying. But they have the same cardiac output. So that's why the index is so important, okay? So based on BMI, height and weight. SVR is normally 8 to 1200, and it could be a little bit different depending on the book. We're not gonna be worried about the details there. If it's 1,200 or more, they're constricted. 800 or less, they're dilated. Okay? The wedge, we want less than 15. On this end, greater than 15, they're wet, and over here, they're dry. Okay? SVO2, I don't know what the range is in the book, but it's around 70. So you can think, you know, we have to get a 70% in nursing school. We also need a 70 in our SVO2. Okay? This is oxygen at the tissue level. So it's telling us if our actual tissue is getting any oxygen. Super important. So if you have a patient who, they're post-op, they've got, I don't know, let's say 1,500 estimated blood loss, and their blood pressure is 85/40, heart rate's 120, their skin is dry. What do you think's going on with this patient?
Probably dry.
They're probably dry. How do we treat a patient that's dry?
Fluids.
We give them fluids, okay? But I've got this awesome catheter that I can gather more data from. So here I am looking at this, and without a swan, I'm gonna dump a bunch of fluids in this patient, hoping their blood pressure will go up, right? So here's the complication, so, or let me just put swan, right? So then we get the swan and we run all the numbers. Oh, and let's say their SAT is 95%. Okay? We run the numbers and we've got a cardiac index of 1.5. We've got an SVR 2000. We've got a wedge 25. And our SAT is still 95%, our SVO2 is 50. And we just dumped a bunch of fluid in that patient. Do you see the importance of the swan and why we use it for cardiac surgery? So here you're like, all right, I'm gonna give some fluids. You run your numbers and go, I'm not giving any fluids, right? So now we can treat a whole different way. Okay, so this is telling us the heart is not pumping well. This tells us we are massively vasoconstricted. This tells us we are way, way high on our fluid overload. This tells us nothing, 95%. And this tells us that we are hypoxic in our tissue. Right? So what do we need to do for this patient? I mean, it's the same patient, but what do we do now? We go up, nope, this isn't happening.
Vasodilate.
We need to vasodilate.
Nitro and
Okay, so vasodilate with something like nitro. Why is nitro such a good vasodilator for a cardiac patient? We give it sublingual when people are having an MI, right? Why?
Opens all the arteries in the heart system.
It opens, it dilates the coronary arteries as well as your other vessels. So here's a heart that's struggling, doesn't have enough oxygen. This is a good vasodilator of all the ones that we have to choose from because it dilates the coronary arteries. Okay? So if we have our heart here and it's pumping against this horrible pressure, the blood can't hardly even get out, right? It's pushing against this pressure. If we make this bigger, it'll be a lot less pressure, easier for the blood to pump out, and so we assume this will get better because now we're able to pump more fluid. My example, when I taught this in class, I would bring 2 different size straws, a boba straw and a coffee stirrer stick straw. So, you know, after clinic, you really, really want a milkshake. And you go buy this awesome milkshake and they say, I'm sorry, it's California and we have no straws. But you're desperate for a straw. So you go to the gas station and all they have are coffee, the little itty bitty straws that, I don't know why they're even straws, they're just to stir your coffee, right? It's a really an interesting thing. But you want that shake so bad, and so, right, you're trying to drink this shake, and you are, with all your might, all the pressure that you can possibly use to get that shake. It's gonna be really hard, right? You're gonna be sweating, your heart's gonna be pumping fast, you're gonna be out of breath, just like this poor heart. Okay? Now, if somebody takes pity on you and brings you a boba straw, and you throw that other straw away, and you put the boba straw in, now you're gonna get brain freeze because you're gonna have so much of that wonderful shake, but you'll be happy because you're able to drink it, right? So that is the vasodilated vessel, the boba straw, versus the vasoconstricted vessel that is the coffee straw, okay? So it reduces the amount of pressure and the amount of work the heart has to do. And remember, I've said before, what is our main goal when we have a cardiac patient?
Decrease the workload of the heart.
Decrease the workload of the heart, and that's exactly what we're gonna do, okay? So we have a problem with vasoconstriction, so we're gonna fix that with nitroglycerin, or something like it. The wedge is 25, what are we gonna do about that? Some of it will correct because we're able to actually pump more blood out of the heart at any given time. We're gonna give a diuretic, okay? So, the diuretic for the fluid volume. Okay, so this is like a complete 180. Here we were giving fluids, here we're giving a diuretic. Okay, so just know what these numbers are, know what they mean, and then if you're given a scenario, which one doesn't belong, which one is the one that I'm gonna question, and what kind of intervention do I think I would do for that? Because if it continues, if your SVR continues at a really high pressure, pretty soon the heart's either gonna quit and not pump anymore, or it's just gonna back up into the lungs, and now you're in pulmonary edema. And now you got a whole nother problem of oxygenating, okay? So that's what the numbers are, in a nutshell. A little Scudmore nutshell. Questions? Yes.
So on this next test, there's a potential for us to get a question that is to this degree where we get a set of vitals and they say, here's your swan readings as well. What are the interventions?
Exactly.
Okay.
They probably won't give you all of these things. They'll give you some vitals, they'll give you some information. The patient had a bypass of 2 vessels, or patient had a valve replacement, patient had a heart transplant. Those do have a couple of unique things, but it's pretty much all the same. They had to crack the chest, they had to give the same meds, put them on a bypass, all that. And then they'll say, if the question maybe is about fluid volume, they're gonna tell you the wedge, and you're expected to know if it's a high wedge, I have to diurese. If it's a low wedge, I can give fluids. So if I made the wedge, if the wedge here was like 5, it doesn't mean I have to give fluids. It means that it's safe to give fluids. Like, it verifies that it's okay to give fluids. Go ahead. That is the correct intervention that you are already thinking of. Okay? Because the reason this wedge is probably so high has a lot to do with how constricted they are, and the blood is going to stay in the heart longer because it can't get out. Okay, so the other thing to think about with this is because it's the PA diastolic, we get this number, we get the wedge number. It's kind of like looking at the left ventricle, like the left ventricular pressure, okay? And it's right at the end of diastole. So it's the end diastolic volume or pressure, okay? So the heart is filling with blood. Right before it's gonna contract, that's when we get the wedge pressure. So it's like how much blood is in the heart right before we try to squeeze the blood out. And so that gives us an idea of, is there too much fluid in there right before we pump, or is it just the right amount? Is there not enough? Because not enough can be just as bad, because the heart's gonna now be a dry pump, it's gonna get injured. But if this is vasodilated like a boba straw and the blood can now get out much more easily, it makes sense that you would have a little bit less pressure in here right before it pushes the blood out, right? You're like, yeah, I don't know what you're talking about. That's okay, because this is an introduction. So this will go down a little just by vasodilating, okay? But if we had the patient, so let's do different numbers. Let's say this was 950 when you ran your numbers, and your wedge is 5. Then you say, okay, yeah, I'm gonna have fluids. Then when you run your next numbers, this might be 8. It's just kind of a verification of your fluid status, okay? A really specific, accurate, not just the urine output and whatever, it's like the actual, source, okay? All right, that's good.
Thank you.
Thank you.
Yeah.